Okay. Now let's move to after optic neuropathies. The next topic is the pupillary disorders. So pupillary disorders, we are talking about the lesions affecting the optic nerve or optic causing abnormal pupil size leading to anisocoria. In practice, the most common it is, as we said, it is the adenoma because the adenoma is, or pituitary adenoma, it is already the most common intracranial tumor or compressing on the chiasma, around 15%. Then the meningioma and the glioma will can cause also. Dr. Islam, visual field improved after treatment? Yes, for early cases, it can improve. Okay, so let's now talk about the pupillary disorders. The pupillary disorders we are meaning about, or we are talking about the changes or the diseases that will affect the pupil size, causing small pupil or large pupil. So let's start immediately. Before we are talking about the pupillary disorders, we need to understand what are the neural mechanisms that affect the pupil size. So we know that from basic anatomy and physiology that the eye or the pupil is controlled by two muscles, the sphincter pupillary muscle and the dilator pupillary muscle. The sphincter pupillary muscle is parasympathetically innervated, while the dilator pupillary muscle is sympathetically innervated. So what is the pathway of the sympathetic system? Actually, the sympathetic system is supplied by the third nerve or the oculomotor nerve. The oculomotor nerve, the parasympathetic fibers arise from the Edinger-Westphal nucleus, which is the parasympathetic nucleus of the third nerve. Then it passes with the oculomotor nerve until they relay in the ciliary ganglion, which is a parasympathetic ganglion. Then postganglionic fibers will pass from the ciliary ganglion through the short ciliary nerves to supply the constrictor pupillary muscle. What is the effect? It will cause constriction. So if there is a lesion affecting the parasympathetic pathway, it will result in a problem that happens more in day or in night. So when is the parasympathetic active? It will should be active, or it will be highly active at night because it will more active in day. Because it will be in day, it will cause constriction of the pupil. So if there is a problem affecting the pupil, affecting the parasympathetic system, it will cause anisocoria or difference in the pupil size, which is more during light. So because the parasympathetic system is active upon light, the light stimulation of the pupil will result in stimulation of the pupillary light reflex by the parasympathetic pathway. On the other hand, the dilator pupillary muscle is supplied by sympathetic fibers. The sympathetic fibers are carried by the long ciliary nerve. So what is the pathway of the sympathetic system? They come from in the brain what's called the hypothalamus. It will descend to the ciliospinal center of Budge from C8 to T2. This are called the central fibers. Then the preganglionic fibers will pass to the superior cervical ganglion, which will relay. Then the postganglionic fibers will pass with the internal carotid artery until they give the ophthalmic nerve. It will reach the ophthalmic nerve, these sympathetic fibers, and this ophthalmic nerve will give the long ciliary nerves to supply the dilator pupillary muscle. So what will be the effect of the sympathetic? It will cause dilatation. And when is the sympathetic is active? During night. As during night, we need to dilate the pupil in order to allow the maximum amount of light to enter the eye. So if there is a problem with the sympathetic system, it will result in anisocoria, which is more in dark, because in dark, the sympathetic system becomes more active. Okay, so based on this understanding, let's see what is the differential diagnosis of anisocoria. Anisocoria could be more in dark, or equal in dark and light, or more in light. Equal in dark and light, this is a physiological anisocoria. Actually, there is a normal population which have a physiological anisocoria. And by let's first analyze what is the word anisocoria. Aniso A, it's absent, iso is equal, chorea is a pupil. So it is absence of equal pupil, or this is a difference in the pupil size between both eyes. There are some people who have normal physiological anisocoria. And in this case, there will be equal in dark and light. There will be no difference in the there will be no change in the difference between both pupils in day and light. And this is how we diagnose a physiological anisocoria. But if there is the difference between the pupil size in the day and night is increasing or decreasing, then we have anisocoria more in dark and anisocoria more in light. So what are the reasons and what are the causes? Let's see. Anisocoria more in dark, it occurs in Horner syndrome, Argyll-Robertson syndrome, iritis, and posterior synechia, and pharmacological meiosis, like if the patient received the pirocarpine or so. Anisocoria more in light occurs more in third nerve palsy, Ades pupil, traumatic mydriasis, or pharmacological mydriasis, such as a patient who receives the atropine. So for Horner syndrome, Argyll-Robertson pupil, Ades pupil, we will discuss now. And for the third nerve palsy, it will be discussed in the strabismus lecture. So we will postpone, or we will discuss all what's related to the cranial nerve palsy, third and fourth and sixth in the strabismus, to see or to discuss the neurological and the strabismological aspects of view regarding this ocular cranial nerve palsy. Okay, Dr. Islam is saying long-standing ages is more in dark. I agree. So this, Dr. Islam, this list I'm presenting not meant to be an exclusive list. So I'm just bringing the most important and the most common for any differential diagnosis. So there will be a lot of other differentials, of course, for any disease or for any case. Okay, so before we understand, or before going through what is Horner and what is Ades and how would we differentiate between both of them, we need first to grasp the normal pupillary light reflex, to grasp the understanding of the normal pupillary light reflex. So what happens when a light is exposed, an eye is exposed to light? Well, the light impulses will stimulate the photoreceptors, which will stimulate the retinal layers layer by layer, bipolar, then ganglion cells, then the impulse will pass into the retina, which will induce impulse or excite the nerve fiber layer, and then the impulse will pass through the optic nerve. Through the optic nerve, it will pass through the optic nerve, then the optic chiasma, then the optic tract. Then it will, before reaching the lateral geniculate body, the pupillary fibers will leave the optic tract to reach the left pretectal nucleus for the left eye. Then the left pretectal nucleus will supply or will send impulses to optic nerve, to Edinger-Westphal nucleus on both sides. So the left pretectal nucleus give impulses to the left Edinger-Westphal nucleus and right Edinger-Westphal nucleus, and vice versa. The right pretectal nucleus send impulses to the right Edinger-Westphal nucleus and the left Edinger-Westphal nucleus. And then from the Edinger-Westphal nucleus, the preganglionic parasympathetic fibers accompany the third nerve to relay in the ciliary ganglion. Then the postganglionic fibers with the short ciliary nerves will supply the ciliary muscle, causing accommodation, and the constrictor pupilli muscle, causing meiosis. So this is the normal pupillary light reflex. If any lesion affecting this red pathway, it will result in afferent pupillary defect. So if there is a lesion involving retinal nerve fiber layer, starting from severe retinal lesion, or optic nerve, or optic chiasma, or optic tract, start till the pretectal nucleus, it will result in afferent pupillary defect. If there is a lesion involving the Edinger-Westphal nucleus and the third nerve until it reaches the dilator pupillae muscle. This green pathway, it is called the efferent pathway defect or efferent pupillary defect. So which one of them will cause anisocoria? Well, if there is a lesion involving the optic nerve, it will be the impulses of the optic nerve will go to the both eyes symmetrically because the pretectal nucleus will supply both Edinger-Westphal nucleus. So the response of both eyes to the affection of the optic nerve will be symmetrical. So there is no anisocoria in case of afferent pupillary defect. So when should the anisocoria happens? The anisocoria should happen when there is efferent pathway defect affecting the pathway of the third nerve that will supply the dilator pupillae muscle, or sorry, it will supply the constrictor pupillae muscle, or it could also happen, the anisocoria could also happen if there is lesion affecting the sympathetic pathway, which will control the dilator pupillae muscle. So we need to understand these concepts. Afferent pupillary defect doesn't cause anisocoria. Efferent pupillary defect will cause anisocoria. Efferent pupillary defect can be due to sympathetic pathway lesion, such as Horner syndrome, or parasympathetic pathway lesion, such as we are going to say, the tonic pupil and so, or traumatic mydriasis by third nerve palsy or so. Okay. So again, afferent pupillary defect, it will be, where is the lesion? It will be present in the retina, in the optic nerve, in the optic chiasma, in the optic tract, in the pretectal nucleus. Those are the 5 locations of the afferent pupillary defect. So what happens in case of relative afferent pupillary defect? When we are, this is the normal right and left eye. When we are shining the light into one eye, there will be constriction of both eyes. This is because the direct reflex of both eyes, the optic nerve, stimulation of the optic nerve in one eye will result in stimulation of the third nerve on both eyes. As we said, the pretectal nucleus will supply the Edinger-Westphal nucleus on both eyes. So when we stimulate one eye, there will be constriction of both eyes. And when we swing the light from one eye to the other eye will constrict as well. What happens if there is afferent pupillary defect? Well, the both eyes here looks no anisocoria. You can see that the both eyes have normal pupil size. When you stimulate the left eye, which is normal, it will constrict by the direct reflex, and the right eye will also constrict by the indirect reflex because the afferent pathway of the left eye is intact and the efferent pathway of both right and left eye is intact. So both will constrict. But when we swing the flashlight from the left eye to the right eye will dilate instead of constriction. Why? Because the right eye is now under 2 forces. The withdrawal of light from the left eye, and which is an indirect reflex, and the direct reflex by constriction of the right eye. Which will win? Which is more potent? It will be the withdrawal of light from the left eye because the left optic nerve is intact. So this will result in dilatation of the right eye instead of constriction. Okay, for more details, again, please refer to the neuro-ophthalmology examination lecture. It will show detailed examination of relative afferent pupillary defect. So what will be the difference if the patient has efferent pupillary defect? In the efferent pupillary defect, it will be different. This will be the pathway, the defect here in this red pathway. This will result in anisocoria more in light. So if there is trauma involving or any lesion involving the Edinger-Westphal nucleus or the third nerve or the ciliary ganglion or short ciliary nerves as in Aegis pupil, or if there is trauma involving the dilator pupillae causing traumatic mydriasis or mydriatic eye drops, all these will result in anisocoria more in light. On the other hand, if there is a sympathetic pathway affection, this will result in anisocoria more in dark, such as Horner syndrome, or if there is Argyll-Robertson pupil, it will result also in anisocoria more in dark, posterior synechia, and myotics. So to remember them, again, I'm just not presenting all full list of the anisocoria more in dark or more in light, but just bringing the most noticeable or most important. So to remember them, remember that there are two fatal diseases that are in red: Horner syndrome and third nerve palsy. Two syndromes or two pupils will cause light near dissociations, and we are going to discuss what is light near dissociation later on, which are Argyll-Robertson pupil and Edis pupil. So it is important to differentiate between both of them. Two traumatic or two mechanical causes, such as posterior synechia and trauma, and two pharmacological, such as myotics and mydriatics. Okay. Okay. So how does a patient with efferent pupillary defect looks like? Again, this is a patient this is a normal individual. This is a normal pupillary light reflex. And what happens if a patient has right efferent pupillary defect? You can see that this patient has anisocoria. The left pupil looks smaller. The right eye here looks larger. So if the patient, we are stimulating the left eye constrict. But when the light impulses pass through the left optic nerve, and then it will pass to the left pretectal nucleus, then it will send the impulse to both Edinger-Westphal nucleus. So the left efferent pathway is intact, so the left eye constrict. But the right efferent pathway is not intact, like if this patient has third nerve palsy. So this will lead to no response when we are stimulating. There will be constriction when we are stimulating the left eye. And when we are stimulating the right eye, no response. The pupil is still dilated. The strange thing here is that the left eye is constricted. Why the left eye is constricted when we are shining the light into the right eye? Because here the patient has a problem in the efferent pathway, not the afferent. So the patient has normal optic nerve, and this optic nerve reaches to the pretectal nucleus, and the pretectal nucleus send the impulses to the Edinger-Westphal nucleus on both sides. The Edinger-Westphal nucleus or the efferent pathway was blocked in the right eye, but the efferent pathway is intact in the, sorry, it is blocked in the right eye, it is intact in the left eye. That's why there is constriction here despite the dilatation of the right eye. Okay. So this patient has a right efferent pupillary defect. I hope that you don't confuse between the afferent and the efferent pathway defects. Okay, so let's start by the Horner syndrome. Horner syndrome, again, almost appear in every exam. Not even a single exam miss Horner syndrome. Okay, so what will be the etiology of Horner syndrome? What will be the cause of Horner syndrome? Horner syndrome occurs due to a lesion in the sympathetic pathway. A lesion in the sympathetic pathway. So what will be the pathway of the sympathetic? There are three order neurons for the sympathetic pathways, starting by the hypothalamus. Hypothalamus is the first order neuron. The fibers will descend through from the hypothalamus through the spinal cord till they reach a center. It's called the ciliospinal center of Budge from C8 to T2. Ciliospinal center of Budge from C8 to T2, it is the second order neuron. Then fibers from the ciliospinal center of Budge will ascend again to pass into the neck, over the pass first on the lung, over the apex of the lung, then pass through the neck till they reach the superior cervical ganglion. So the superior cervical ganglion is in conjunction with the common carotid artery, then external carotid and the internal carotid. Then it will relay in the superior cervical ganglion since it is a sympathetic ganglion. Then postganglionic fibers will pass with the internal carotid artery until they reach the they pass with the internal carotid artery until they reach the ophthalmic nerve. So it will give branches that will pass with the ophthalmic division of the trigeminal nerve to supply different structures on the eye. What will it will supply what? Supply the dilator pupillae muscle, resulting in pupil dilatation. It will also supply the superior tarsal muscle, which is called the molar muscle, and the inferior tarsal muscle. So these muscles will cause lid retraction. So that's why those patients who have hyperthyroidism have lid retraction, because they have overstimulation by the sympathetic overactivity to the superior tarsal muscle and the inferior tarsal muscle. And on contrary, when there is damage to the sympathetic pathway, this will result in that the lids will close. There will be paralysis of these retractors. Okay. So basically, when there is damage to the sympathetic pathway, there will be paralysis of these muscles. So the sympathetic will also supply the superior tarsal muscle or the molar muscle, which is a weak elevator of the eye. So paralysis will lead to ptosis. The sympathetic will supply the dilator pupillae muscle, so the paralysis will result in miosis. The sympathetic also will give supply to the sweat glands of the face. So there are some fibers which will pass with the external carotid artery to the sweat glands of the face. So damage will result in anhidrosis. So basically, these are the main manifestations of the Horner syndrome. So what will be the causes of Horner syndrome? What will result in Horner syndrome? Any lesion involving the sympathetic pathway from its center to the end, from the hypothalamus, passing through the spinal cord to the ciliospinal center of Budge, to the superior cervical ganglion, passing through the chest and the neck, and then entering again into the brain, will result in Horner syndrome. So this can be classified into a group of categories. We can classify it to central, preganglionic, and postganglionic. Central, starting from any lesion involving the hypothalamus with the central fibers passing through the brainstem, cervical spinal cord, thoracic spinal cord, the ciliospinal center of Budge, which can be due to brainstem stroke, such as Wallenberg syndrome, spinal cord injury, such as Brown-Sequard syndrome and syringomyelia, brain tumors, brainstem hemorrhage or pontine hemorrhage, lateral medullary syndrome, demyelinating disease or multiple sclerosis, malformations such as Arnold-Chiari syndrome, and meningitis. If there is lesion involving the preganglionic fibers, which will start from the ciliospinal center of Budge till passing through over the lung apex to the stellate ganglion or the superior cervical ganglion, any lesion involving this pathway will result in preganglionic Horner syndrome, such as tumors involving the apex lung, such as Pancoast tumor, or iatrogenic, such as birth trauma or central venous catheterization, enlarged lymph nodes in the neck, such as lymphadenopathy, arterial dissection, such as internal carotid artery aneurysm, common carotid artery aneurysm, and postganglionic, there will be superior cervical ganglion or third nerve. Just hold on for a second, please. Okay, sorry for the interruption. Okay, so for the preganglionic, again, we are speaking about any lesion involving the any lesion involving the sympathetic fibers as they travel from the ciliospinal center of Budge until they reach the superior cervical ganglion, which can be due to tumors or iatrogenic by birth trauma, enlarged lymph nodes, or tumors in the neck. Some arterial lesions or dissections, such as common carotid artery dissection or cervical rib. Postganglionic lesions also can cause Horner syndrome. Like by postganglionic, we are speaking about any lesion involving the sympathetic fibers after the postganglionic, after the superior cervical ganglion, like involvement of the internal carotid artery or ophthalmic nerve, iris dilator muscle. All this can result in Horner syndrome, such as dissection of the internal carotid artery, cluster headache, cavernous sinus, tumors, or herpes zoster infection. Okay, so this is a full list of, or most of the causes that will result in Horner syndrome. Let's now discuss the manifestations. As we mentioned, those patients will present with ptosis. Why those patients present with ptosis? Because there will be paralysis of the molar muscle. So this is very characteristic that those patients would have anisocoria, and this anisocoria, you can see that the abnormal pupil is the smaller one. This abnormal pupil with a smaller one with ptosis is almost always, it is a Horner syndrome. So those patients present with ptosis due to paralysis of molar muscle. They will present with miosis due to paralysis of dilator pupillae muscle, resulting in anisocoria more in dark. They will have a facial anhydrosis due to which occurs with preganglionic lesions, as the postganglionic lesions will skip the fibers, the sympathetic fibers that will supply the sweat glands of the face. There will be apparent ophthalmos, as those patients will have a mild ptosis of the upper lid, and also there is absence of lid retraction of the lower lid. So there will be a narrowing of the palpebral fissure, which will give the appearance of presence of enophthalmos. Hello, can you hear my voice? Hello? Okay. So this is for the facial anhydrosis, apparent enophthalmos, heterochromia. What is heterochromia? Heterochromia meaning that there will be, here is the heterochromia. You can see that in the congenital Horner syndrome, the migration of nanocytes is dependent on the sympathetic system. So if there is abnormal or impaired sympathetic system, this will result in not only miosis and ptosis, it will also result in heterochromia, resulting in abnormal pupil or different pupil color from the other eye. In children, very important to know what are the causes of Horner syndrome in children. Like the most common is trauma, like birth trauma and neck trauma, such as we said, it can cause preganglionic Horner. So those children who are born with Horner syndrome, they can be due to trauma, due to birth trauma, or they can be subjected to neck trauma. But if the history of trauma is excluded, then the most serious to consider is the neuroblastoma. So we will discuss this in the pediatric ophthalmology. So neuroblastoma is very important to exclude for patients, for children with Horner syndrome. If a patient with acute Horner syndrome with neck pain, this is a common scenario in the exams, consider always the internal carotid artery dissection. Acute Horner with the neck pain. Here we come to the maybe a little bit silly topic that we discuss every now and then in the basic course, in the FRCS3 course, in the FRCS2 course, because unfortunately it's asked in all exams. Doesn't it, no matter what exam you are applying for, they like to ask about the pharmacological testing of the Horner syndrome. So let's try to simplify it to make it less painful. So if we have a patient with right Horner syndrome, so this means that the right pupil is smaller than the left one. We have two kinds of tests to diagnose and to level. So two tests for diagnosis, which is cocaine test and the apraclonidine test. And two tests for leveling to detect whether it is preganglionic or postganglionic, which is the hydroxyamphetamine test and the adrenaline test. So what is the basis of each test and what is the response of each test? The cocaine prevent the reuptake of the norepinephrine from the neuromuscular junction between the nerve and the dilator pupillary muscle. So it will lead to that the effect of the norepinephrine will increase and will so it will affect the normal eye. It will cause dilatation of the normal eye. However, for the Horner syndrome, it will not dilate the Horner because it will be still there will be no norepinephrine in order to be reuptaken, so it will cause no dilatation of the Horner syndrome. So again, this is a case this used to confirm the diagnosis of Horner syndrome. Since those patients with Horner syndrome don't have intact sympathetic innervation, this cocaine will not be effective to prevent the reuptake of norepinephrine. So it will not dilate the Horner. But for eyes with intact sympathetic innervation, this will result in block the norepinephrine uptake, resulting in increase the norepinephrine in the neurosynaptic junction, leading to dilatation of the pupil. So again, what will be the first test to diagnose Horner? It will be the cocaine. What will be the effect of cocaine? It does not dilate the Horner. Remember, the right is the Horner, but it will dilate the normal pupil. Another test used for diagnosis of Horner syndrome, but with different interpretation, will be the apraclonidine test. The apraclonidine test, it is an alternative to the topical cocaine to confirm the Horner syndrome. It is an alpha adrenergic agonist, meaning that it will cause pupillary dilatation. And so, but it is weak, so it will not cause pupillary dilatation in the normal pupil because it will stimulate the alpha-1 receptors. It is and since those patients with Horner syndrome, they don't have sympathetic innervation, so they will show upregulation of the alpha-1 receptors. They will show increased number of alpha-1 receptors. And so even this weak apraclonidine will be able to dilate the right pupil, the Horner pupil, because of the denervation hypersensitivity. So the apraclonidine will cause dilatation of the Horner syndrome or the Horner pupil because of the upregulation of the alpha-1 receptors, leading to denervation hypersensitivity. So it will cause dilatation. But for the normal eye, those don't have upregulation of the alpha-1 receptors, so it will not work. It will not cause dilatation of the normal pupil. So apraclonidine dilates the Horner. Cocaine does not dilate the Horner. These tests used for diagnosis. Okay. After diagnosis, we need to know now what is the level. How would we know whether the lesion is preganglionic or postganglionic? We have two drugs, the hydroxyamphetamine and the adrenaline. Hydroxyamphetamine will potentiate the release of norepinephrine at the neurosynaptic junction. If the patient has preganglionic, it will dilate the pupil because they will already have norepinephrine, but they will just, it is just a little bit weak or minimal. So because the postganglionic nerve is intact, so this postganglionic nerve will secrete norepinephrine. So the preganglionic will dilate by the hydroxyamphetamine, and also the normal pupil will dilate. But if the postganglionic nerve is damaged, or if there is postganglionic Horner, so there will be norepinephrine is secreted by this postganglionic at the neurosynaptic junction, resulting in that the postganglionic will not dilate. Here, the postganglionic will not dilate. And of course, the normal pupil will dilate. So the hydroxyamphetamine will dilate the preganglionic, but will not dilate the postganglionic. Okay. So this will be helpful to diagnose the preganglionic from the postganglionic. Another test used for differentiation is the adrenaline. Adrenaline is destroyed by the monoamine oxidase enzyme. So for those patients who have preganglionic, they have the normal monoamine oxidase and normal adrenaline. Like they don't have a problem with the monoamine oxidase. But those patients with the postganglionic nerves, they don't have norepinephrine, so they will have less monoamine oxidase. They will have denervation hypersensitivity to adrenaline. So even with minimal dose of adrenaline or diluted adrenaline, they will dilate, the postganglionic will dilate because of the denervation, again, denervation hypersensitivity. Because actually the postganglionic will not have monoamine oxidase, and this monoamine oxidase enzyme is the one which is responsible for destruction of the adrenaline. So once the adrenaline doesn't have any negative feedback, there is no monoamine oxidase to inhibit it because it is not secreted from the postganglionic. This will result in upregulation of the photoreceptors, increase the sensitivity to adrenaline, so it will dilate with the adrenaline. So eventually, the adrenaline will not dilate, the diluted adrenaline actually will not dilate the preganglionic, but it will dilate the postganglionic. Again, to summarize all the workup, all the pharmacological testing, we have 2 drugs for diagnosis, 2 drugs for leveling. Cocaine will not dilate the Horner. Apraclonidine will dilate the Horner. So both of them will be important for diagnosis. Hydroxyamphetamine will dilate the preganglionic but will not dilate the postganglionic. Adrenaline will not dilate the preganglionic, but it will dilate the postganglionic. Hard mission to explain, but I hope that you understood it. Hold on for a second, please. Okay. For Horner syndrome, it can be caused by internal carotid artery aneurysm, or for investigations, we do the imaging like internal carotid artery aneurysm, MRI and MR angiography or CT angiography of the neck. So this is important if the patient has neck pain. So you should do MR or MRI or MR angiography or CT angiography for the neck. Neuroblastoma for imaging of the head and the neck and chest, and urinary catecholamine metabolites, or the catecholamine metabolites are present in the urine for patients with neuroblastoma. So you target your investigations depending on the cause, and basically those patients will need neuroimaging on the head and the neck and chest to detect where is the lesion, like if there is a Pancoast tumor or if there is a neck mass. You do investigation to detect the cause. For that, the treatment and prognosis also will depend on the etiology. Okay. Any questions in the Horner? Mechanism of the action again, please. Okay. So cocaine prevents the reuptake of norepinephrine from the neuromuscular junction. The apraclonidine will potentiate the release of norepinephrine, will potentiate the release of norepinephrine, so it will stimulate the alpha-1 receptors, which are already upregulated in the alpha in the Horner syndrome. So it will act by denervation hypersensitivity. Hydroxyamphetamine will the apraclonidine will potentiate will stimulate the alpha-1 receptors, which are upregulated In the Horner syndrome, the hydroxyamphetamine will potentiate the release of norepinephrine at the neuromuscular junction, so it will dilate the preganglionic and not the postganglionic. Adrenaline will act by denervation hypersensitivity. Since it is present on the preganglionic, it will not act. But since that there is no monoamine oxidase in the postganglionic, so there will be no enzyme to destroy the adrenaline, and there is upregulation of the upregulation of the receptors on the postganglionic, so adrenaline again will dilate the postganglionic. Okay, for the tonic pupil, it is a pupil occurs, or it is a damage occurred to the pupil due to parasympathetic ciliary ganglion or nerves. So tonic pupil meaning that the pupil is not able to respond normally. There is a lag of its response. This is what's meant by tonic pupil. And this is due to damage of the parasympathetic ciliary ganglion or parasympathetic ciliary nerves. This is the ciliary ganglion, and this is the short ciliary nerves. If there is damage here, this will result in tonic pupil. The tonic pupil can be due to many causes. It can be primary or secondary. The site it can be due to in the ciliary ganglion or the short ciliary nerves. It can be primary or idiopathic, such as Aegis syndrome or Holmes-Aegis syndrome, that's associated with areflexia or absence of the deep tendon reflexes. Or it can be secondary due to a variety of causes, such as diabetes, syphilis, which can also cause both Aegis pupil and tonic pupil and Argyll-Robertson pupil, trauma, degeneration, Parkinson's disease, progressive supranuclear palsy, iatrogenic trauma, myotonic dystrophy, and familial dysautonomia or Rayleigh-Day syndrome. So what is the criteria for those patients who have tonic pupil? Those patients have mydriasis. Those patients have anisocoria more in light. So they have dilated pupil more in light. Vermiform movement of the pupil. So you see that the anisocoria, let me show you something. Vermiform movement of the pupil, meaning that those patients have what's called segmental denervation. Segmental denervation of the pupil, resulting in when you when you are trying to stimulate the pupil by pupillary light reflex, you can see that the edge of the pupil has a vermiform movement or like snake movement because of some parts of the constricted pupillae constrict and the other part doesn't constrict. I don't know if you can appreciate it from here, but you can find it's very clear here at this area. This is called the vermiform movement of the pupil. Also, they have what's called light near dissociations. Light near dissociations, meaning that when you stimulate the pupil by light, there will be lost light reflex. When you stimulate by near reflex, you will find the intact near reflex. However, it is tonic, meaning that it is slow. So stimulating by the light, there is no constriction of the pupil. Stimulation by near target, there is constriction of the pupil, but this constriction is tonic or slow. Those patients also have decreased deep tendon reflexes in the full Holmes-Aegis syndrome. So this is called Holmes-Aegis syndrome. They will have areflexia or hyporeflexia. Pharmacological testing is much more easy than Horner syndrome. Those patients will respond to 0.125 pilocarpine, leading to constriction due to denervation hypersensitivity. So pilocarpine will is, in order to cause constriction of the pupil, it should be at least the concentration of 1%. So 0.125 diluted pilocarpine will not cause constriction of the normal pupil. However, for those patients who have Aegis pupil, they will constrict. Why? Because of the same principle of denervation hypersensitivity. Those patients have denervation of the short ciliary nerves, so they show upregulation of the muscarinic receptors or the parasympathetic receptors, or the so with even slightest dilution or slightest concentration of the parasympathomimetic or the pilocarpine, they will show constriction. So this will be the diagnostic test for Aegis tonic pupil. Investigations for age is usually not needed. The treatment of those patients will be treated by diluted topical pilocarpine or physostigmine can be used for symptomatic relief in case of severe photophobia. So those patients have dilated pupil, they will have dilated pupil so that they will experience photophobia. So you can give this diluted pilocarpine in order to relieve this photophobia. For the prognosis, those patients usually have good prognosis. It is a benign condition, usually improves by time. So those experiencing photophobia or blurring of vision, just reassure those patients that this condition will resolve with time, usually from months to year. Another condition that is similar to the age-stonic pupil, but it should be differentiated from it. It is called the Argyll-Robertson pupil. For the Argyll-Robertson pupil, it is different from Aegis pupil that they have bilateral, irregular, and myotic pupil. Those patients usually have history of syphilis. It is one of the most common causes of Argyll-Robertson pupil. Unlike the Aegis, it will not cause dilated pupil. It will cause a small pupil, myotic, and irregular pupil. They also have light near dissociation, meaning that they have lost the light reflex. When we are stimulating the pupil with pen light, there is no response, but they have intact near reflex. It constrict by near reflex. So what will be the difference? That in this case, in the Argyll-Robertson pupil, it responds briskly to the accommodation. It will show rapid response to accommodation, unlike the tonic response of the Aegis pupil. So to summarize, the Aegis tonic pupil, there will be light near dissociation, no response to light. Response to the light is poor. And there is present response to accommodation, but accommodation is slow and prolonged. And it starts as large pupil, and later on it becomes small pupil. That's what's called little old AD, small pupil, tonically constricted. On the Argyll-Robertson pupil, they have bilateral small pupil that also don't respond to light. But the difference is that the accommodation here is quick. So they have brisk response to accommodation, and it is associated with neurosyphilis. Okay, so this Argyll-Robertson pupil. To summarize the most important causes for anisocoria, we have anisocoria more in dark and anisocoria more in light. For the scenarios in the exam, when you find a patient who has anisocoria more in dark or anisocoria more in light, think of these reasons. Think of the critical or life-saving reasons, such as Horner syndrome, which causes anisocoria more in dark, especially if a patient is young with acute Horner, with history of trauma or lung tumor, if there is mild ptosis with a small pupil, anhidrosis or preganglionic, which will make you think of preganglionic Horner syndrome. If there is facial pain or neck pain. So these are when you find them in a scenario, you are thinking of a Horner syndrome. Third nerve palsy, again, as I told you, we will discuss it in the strabismus. So, but again, third nerve can be present due to life-threatening conditions such as intracranial tumors or aneurysm. So especially you are suspecting that if a patient is young with history of trauma, aneurysm, brain tumor with no vasculopathic risk factors. Aegis people, you consider it if it is female. So I forgot to tell you that Aegis is more common in females and more common to be unilateral. So 2/3 of cases are female, 2/3 of cases are unilateral. More with reading a problem, and it responds to constriction of 1.25 pilocarpine. The traumatic also, if there is history of trauma. The pharmacological, if there is history of intake of eye drops. So this is the basic and the most important differential diagnosis of anisocoria, and with important clues about each disease. Okay. So we will end our lecture by this topic today. Does anyone have any question in the anisocoria? Is everything clear? Okay, thank you very much for your attention, and thanks for for your concentration and for your participation in this lecture. Hope that it was helpful and useful for you. And see you next time. We will finish the neuro-ophthalmology. So we will continue the supranuclear disorders and myopathies and other neurological disorders. And so we will conclude the neuro-ophthalmology, and then we will move to the pediatric ophthalmology and strabismus. Thank you, and see you next time.